We were discussing at length, like, where is that disconnect? Because the evidence suggests, certainly at a public health level, that when we talk about things like DALYs, and listeners of the podcast that recall kind of Ben Jones and Max Sherman's stuff around harm intensities, we kind of can associate DALYs of about 2,200 years lost to death and disability per 100,000 of the population, which is equivalent to smoking and twice as harmful as alcoholism and road traffic deaths. So it's right up there at this is an intolerable level of risk, yet almost zero funding comparatively to those other other risk factors in dealing with the problem. And there's this weird psychological thing that I was talking to you about, that this chronic esoteric nature of air quality, that people just can't quite join the dots, change simple behaviours to mitigate long-term risk.
Because it's invisible?
Because it's invisible, and we were talking about the fact that because it's a basic instinct to take a breath, you basically don't have agency to make a choice not to breathe. So I think somehow there's a mental wiring going on that makes people not think about air quality because they just simply don't have a choice. They have to breathe. And I think that perhaps extends in then to some of the longer term chronic risk mitigation. Because I can't see any other way of painting it. We know it's the same with radon. You can't give a radon test away. And there isn't I joke, it's the slam dunkiest of dunky air quality pollutants, because we know the source, we know the harm it causes, we can measure it cheaply, we can solve the problem. Like there isn't a pollutant that has a more direct straight line to a particular health outcome than radon. And we know, and it can't be mistaken for anything else, and we can measure it easily. And yet we're still sitting here today with radon in people's homes.
But again, that's where the psychology comes into that. You know, the reality is that there are probably 4 or 5 more visible, easier to comprehend, more well-known, understood about, talked about, socialized, you know, as being acceptable, go and do some exercise, or unacceptable, smoking. Whereas this, I don't think that this has reached the public consciousness in quite the same way. And I think like that's probably a big part of the shift that would be required here. And I'm talking as a relative outsider, you know, thinking about how it might work together. But the reality is that what a lot of the behavioural change that might be required to improve a lot of this stuff is, it's another chore in the day for people. You've got to open your windows, you've got to make sure you're ventilating this, you've got to not use that, you've got to... and I would be interested to kind of quantify that in people's experiences of their daily lives. So if you think, you've got to get up, you've got to get your kids out of bed, you've got to get their school uniform ready, you've got to do the dishes, you've got to unpack the dishwasher from the night before. All of a sudden,
Telling me now I've got to put the cooker hood on.
Yeah, right. Yeah. So here are 3 or 4 other things that you need to fold in because you have to do this. But if people are seeing this as the 6th, 7th, 8th most important health thing, and they're already eating well, and they're already doing exercise, and they already have stopped smoking, and they're already cut down on their drinking, it's hard then to motivate people to go again and build the next one.
But you must see that in health all the time. I mean, you're talking about the difference between preventative health and active health measures, and again, you're competing for people's times to change dietary behaviours, cleaning behaviours, whatever the behaviours that might be putting them at risk for, respiratory conditions, for example, changing hoovering in a different way or whatever it is.